When you think of immunotherapy in its role, I think of two situations. The first situation are patients that have now gone through induction therapy and they still have a lot of tumor, or patients that have relapsed after initially going into remission. They may have even already had transplant. Um, so I view immunotherapy as a model of hope for these patients that have had a marginal response to initial therapy or relapsed after having previously had a good response. When I mentioned sentinel articles before, I should have included this one by Rajan Modi. That was published in 2017 in Lancet Oncology. And this was a children's oncology group trial where half of the patients they had relapsed or had refractory disease, and half the patients just got chemotherapy. And the other half of the patients got chemotherapy, in which the chemotherapy was combined with a monoclonal antibody at that time being dinutuximab. What Dr. Modi published was a clear-cut survival advantage in terms of response for the group that received chemotherapy with the antibody given it concurrently. In fact, if I recollect from the paper, I believe the response rate to just the chemotherapy arm was in the 5 to 10% range, and the response rate in the chemotherapy with the antibody arm was slightly over 50%. That was a landmark publication because for us, it told us that we can now start giving hope to the patients that we previously couldn't give a lot of hope to. Those patients that had relapsed, those patients that had refractory disease. Now we had another tool in our toolbox, this combination of giving chemotherapy with antibody and starting to see some dramatic responses to that combination. So I said that there's two roles for immunotherapy. The first role is for those patients that have now completed induction therapy and they've got too high a disease burden to go to transplant, to try to use chemoimmunotherapy as a bridge to lower their Curie score, a way to lower their disease or tumor burden to get back to transplant. And certainly for those patients who have relapsed or relapsed disease, is another way to get their tumor back under control, to then potentially go on to other modalities after that. Unfortunately, I can't promise you that chemoimmunotherapy is always the answer, that I can promise cure for a child, but I can say this, it's dang effective therapy in many patients with some pretty dramatic responses we've seen over the years. In fact, right now within the children's oncology group, this whole concept of chemoimmunotherapy is the platform for their current phase 3 trial. And right now in North America, if you enrolled on this is the current upfront neuroblastoma trial for high-risk neuroblastoma, patients are randomized to either get the standard 5 rounds of chemotherapy during induction, or to get these cycles of chemotherapy in which you're getting immunotherapy or antibody at the same time. So basically, half the patients are randomized for induction to just get chemotherapy. The other half are randomized, it's like a 2-arm thing, to get chemotherapy with immunotherapy during induction. And the reason for this is that we saw that chemoimmunotherapy was working so well for relapsed or refractory patients. It's like, why don't we move it up front and see if it helps our induction response rates? So that's what's being looked at right now within the COG group. That's the first role for immunotherapy. The second role for immunotherapy, I touched base on a little bit ago, that I view transplant is going to become a platform for novel immunologic methods to target neuroblastoma. Ways that we can develop not so much chemotherapy that just blankets cells that are actively growing and dividing, but to develop tumor-targeted bullets, where we take somebody's immune system and literally reprogram it to target just proteins that are on the outer shell of their tumor. How far away from doing this? Well, not far at all. In fact, right now on clinicaltrials.gov, that's the FDA's website, there's 26 clinical trials using what are called CAR T cells to target neuroblastoma. There's 21 clinical trials on the FDA's website using what are called NK CAR cells to target neuroblastoma. Basically, what we're doing is we're taking a patient's T cells or NK cells, we're taking a portion of their immune system, their white blood cells, NK cells, T cells are part of your immune system that do targeting. And we're reprogramming them to just target your tumor. How well will this work? Well, the proof will be in the pudding. Many of these clinical trials are currently ongoing in phase 1, phase 2, and hopefully soon even phase 3 trials around the country, but also around the world. Some novel immune type trials like this being done not only in North America, but in Europe and also in Asia. I think for us, it's the hope for the future. It is not that we're going to be going back to just escalating up that ladder, rungs of the ladder, with higher dose therapy for transplant, but that now we're just going to be using one particular rung that just targets just where that genetic defect or that gene defect is on that neuroblastoma, and just hammer that rung with this targeted therapy. So when you ask me what is the role for immunotherapy, I look at it in terms of two things. One being chemoimmunotherapy, where we give chemotherapy with antibodies in response to patients that have not had a great response to induction therapy or that have relapsed after therapy. And the second is to use some novel immune type mechanism to reprogram T cells, immune surveillance cells to target a patient's neuroblastoma.